Okay, the institution must show that the pharmacy compounds all sterile IV preparations except in an emergency. So if we had to prepare an IV drip on the unit because it was an emergency, we would use the very clean white tray located in the clean supply room. Just remember that. Okay, so here it is, our sterile slash clean prep tray that we would use in such an emergency. I would try to stay away from this if at all possible. And while we're at it, let's talk about the silent night. You would always use the little baggies for each patient's individual medications. Again, in the day, we had our own little pill crusher and we would just crush everybody's pills all together, little Prograf, a little oppressor. So for obvious reasons, we want to keep everybody's medications individualized. High alert and look-alike, sound-alike medications. So pharmacy has done a really good job making sure that these are separated in the Omnicell, so anything that looks the same or sounds the same will not be found side by side in the Omni cabinet. I think we also have signage on the Omnicells to make sure that we're aware of medications that may be look-alike, sound-alike. Why is this important? Okay, so again, another little story. So Benadryl and vasopressin both come in little vials with blue labels. Can you imagine that our medications in the day were delivered in little brown bags, and when you work nights, you weren't allowed to turn any lights on. So can you imagine that I pushed 40 units of vasopressin instead of Benadryl on Dr. Livingstone's patient? And you can just imagine how impressed he was with me. But the good news is soon after that, the hospital, and maybe because of this, the hospital invested in the Omnicell system. Medications are given timely. So medications are designated as either routine, time critical, now, or stat. Any overdue meds are displayed as red in the EMAR. Medications that are designated as time critical are things like IV antibiotics, IV anticonvulsants, pain medications that are given more frequently than every 4 hours. And you would know that you have to administer them at exactly the right time or 30 minutes before, 30 minutes after for a total window of 1 hour. Non-time critical medications are meds that are prescribed more frequently than daily, but less frequently than every 4 hours. So you've got 1 hour before, 1 hour after for a total window of 2 hours. And for meds that are prescribed daily or patches that may be weekly or Monday, Wednesday, and Friday, those things you have 2 hours prior, 2 hours after for a total of 4 hours to give the med. Therapeutic duplication. Okay, so you cannot have multiple medications prescribed for the same clinical indication. For example, Percocet 1 tab Q4 for severe pain and morphine 2 milligrams IV Q2 for severe pain. So 2 things for severe pain. If you notice something like this, you would get the practitioner to change it, maybe making the Percocet for moderate pain, the morphine for severe pain. You also must pick the PRN that matches the documented assessment. So if you're documenting moderate pain, you need to be giving the PRN that matches moderate pain. So always pain assessment and reassessment is a hot topic. Remember that we have to assess the pain immediately before we give anything for pain and within an hour after giving any medication for pain. If a medication is late, remember it will turn red on your EMAR and you need to document the reason why the medication was given late in the medical record. And contrary to popular belief, it's really okay to have overdue meds. You just want to be documenting why they're late, perhaps rescheduling the dose or getting pharmacy to reschedule the whole thing. You don't want to skip things and just to get rid of the red box on your EMAR. If medications are not given or missed, we need to document the reason in the EMAR, and also we need to document that we notified the MD or provider. So that's something that actually gets missed quite a bit. Telephone orders. So can you take a telephone order? And the answer is yes. You're going to document that the order was read back and verified, and that's of course one of the drop-down choices. How long does the practitioner have to sign the telephone order? And crazy enough, the answer is 1 week, but we will try to get it done before the end of the shift. How do you know if you have a telephone order that needs to be signed? And that's because there's a caduceus sign next to it in your orders. Patient and family education. So how do we do that? We always will assess and document readiness. We will document that education was done in the preferred language. IPOCs are suggested by our assessment, and some of the documentation for education is contained within the IPOCs. Other learning would be documented in the adult learning section, and you're going to locate the documentation under results review or in notes under patient education. Okay, consents. Make sure that you know where to find the consent, be it paper or in the EMR. When do consents expire? So the consent is good for the entire hospitalization. Blood consents might be embedded in the surgical consent, so you need to be careful with that. Emergency consent is only good for that one time. So if it's an emergency consent for blood, it's good for only that one transfusion. Emergency consents for procedures should only be used for true emergencies and if the proxy is not readily available. Consents need to be done in the preferred language, and you need to demonstrate the use of an official translator. The physician may translate for themselves if they're fluent in the language. We cannot unless we are certified translators. Safe handling of hazardous drugs. We would want to know what kind of PPE to wear. We would want to know how to correctly dispose of drugs. What would we do in case of a spill? And do we have eye wash stations? So regular trash, what can we put in regular trash? We can put empty IV bags, any tubings or vials that are empty, so less than 3% remaining. They all can go in the regular trash. Sharps containers, so syringes, ampules, and anything that's sharp can go in the sharps container, but it would be nice if we didn't put gloves and garbage in the sharps container. What doesn't go in the sharps containers would be patches and medications. Unfortunately, it's not uncommon for people to go into the sharps container and retrieve the patches that we've disposed there and narcotics. So it's okay to dispose of maintenance IV fluids down the sink. Anything with electrolytes is okay, but nothing with medications should go down the sink. And that's really important because for a long time we really haven't been environmentally friendly, so please be careful what you do dump down the sink. All controlled substances, PO, IV, injectables, patches, must be disposed of in the little white bins by the Omnicells, and all waste must be documented in the Omnicell or in Anywhere RN. Very, very important, obviously. The big black bin in the clean utility room is for partial IV bags, partial vials, pills, capsules, ointments, solutions, wrappers, really anything else except no narcotics, no controlled substances go in the bin. Okay, pain assessment and management. So we must assess the patient's pain level on admission. We need to use an appropriate pain scoring system. So we use the numerical system and CPOT for our critically ill patients. We must offer non-pharmacological pain relief options. So using repositioning and massage, heat and cold therapy, those kind of things. Also that we use a multimodal approach to pain management. We can talk about using non-narcotics like IV Tylenol, for instance, and that we use the lowest effective dose to relieve the pain. They want to see that we're establishing realistic goals. So sometimes it's not possible to say pain-free, but more so is able to use the TriFlow, is able to get out of bed and walk. It really is helpful if the patients and the families understand that it's virtually impossible to have no pain after a major surgery. We already talked about assessment and reassessment before and 1 hour after giving pain medicine, and then also not forgetting to assess sedation level after administering opioids. So other ways that we keep our patients safe would be to make sure that we're scanning our medications, so BCMA, 2 forms of identification. We always check the name and the MRN. We scan our labels for our labs. We label the specimens in front of the patient in the patient's room. We always do bedside shift report. We reconcile medications. We assess for fall risk at the beginning of each shift, and if our patient status changes, we assess for the risk of skin breakdown every shift. We assess for the risk of suicide on admission. And it's always good to throw in hand hygiene. We perform hand hygiene. We stop any procedure that breaches infection control, and we do timeouts before any procedure. It's important that we identify patients at high risk for adverse drug effects, especially after giving narcotics. So we would be able to talk about monitoring end-tidal CO2, and also that we have acute pain service for complex cases. So another broad category of things you need to know will fall under infection prevention and control. Of course, they'll be observing very closely to make sure that we don't have food or drink in the patient care areas. Please start now by making sure you don't have personal belongings at the bedside, and make sure that no leftover coffee cups are sitting around, because that's a for sure RFI. They will be looking to make sure that our soap and Purell dispensers and our paper towel holders are full and working, so good luck to us. No, but if you see one that is broken or empty, please point it out and get it replaced. Check things like the linen cart, making sure that the linen is covered, that the door is closed, don't let it be jammed open, that the bottom shelf has a plastic liner, and that the cart is clean and free from dust. They'll be coming to the bedside and observing that all the patient items are labeled and dated appropriately. Checking that clean and dirty supplies are not stored in the same area, or that things that are supposed to be clean are actually clean when they're in the clean utility room. They'll be looking at equipment and horizontal surfaces to make sure that they're clean, free of dust, that they don't have any tape residue on them. Looking in the clean utility room to make sure that all the equipment is bagged. So PPE is sure to be a hot topic. You want to make sure that you know the precaution signs. You want to make sure that you're not wearing PPE outside of the patient's room. You don't need gloves to carry a specimen. They'll be watching for that. You want to know about the banner bar and isolation status. You want to make sure that you're including isolation status in your SBAR reports. And you want to be able to show that you have educated the patient and their family about infection control, and especially about hand hygiene. And of course, they'll be watching very, very closely to make sure that we're all performing appropriate hand hygiene. So not only is this about nursing washing their hands, but of course everybody. And it's really expected that as the patient advocate, we are watching for the best interest of the patient. So honestly, if you have somebody at the bedside and they are not using appropriate PPE and not washing their hands, it is the expectation that you respectfully intervene and make sure that they change their behavior. So it's our responsibility to speak up, and honestly, if you have any issues with anybody, it needs to be escalated to myself, to the A&Ms, and our medical directors will deal with any physicians that are offenders. So just like other manuals, you'll need to know where the infection control manual is, and that's in content directory on the JET portal. And if you're unsure how to find that, please take a couple minutes and make sure that you're comfortable with that. They'll probably want to know that we know how to don PPE correctly, so hand hygiene, gown, mask, eye protection, and then gloves. And that also we're doffing correctly, so gloves, gown, eye protection, mask, and then hand hygiene. A favorite question is, how do you know that the gloves fit you? And you would want to be able to answer that they fit if they have little wrinkles in them. They're not going to be too tight. They have to have little wrinkles in them. You will be observed to make sure that we're wiping down all of equipment between patients. And although it feels like statement of the obvious, you want to be able to articulate that you would wipe down equipment after patient use and before patient use. They'll be checking to make sure that all patient care items are 36 inches away from the water supply. So please don't be putting anything on the sink, and that's why we had the barrier installed in the clean utility room. No outside shipping containers or boxes can be at the bedside. So please be very careful with the dialysate boxes that you're not stacking them or storing them at the bedside. There are very specific regulations about how trash, sharps, and soiled linen are stored. So even as far as how many linen bags you can have in the unit at any given time and how far away from each other they have to be. So if you see us running around hiding the linen baskets, you'll know that we're not actually crazy. It's just that we actually have too many in the unit. And of course, any biomedical waste is disposed of in red bags, and we keep it in the soiled utility room until it's collected. A couple things about our wipes. So it's important to know that it is actually the wet time that is important for killing germs and bacteria. So for Sanicloth, the wet time is 2 minutes, and for the bleach wipes, it's 4 minutes, and if you can't remember, it's written on the label. It's also very important to make sure that we close the lids on these containers, because if the wipes dry out, they don't work. Okay, the nutrition fridge. So all items must have expiration dates. They must not be expired. No unlabeled food in the refrigerator, and the fridge must be clean and defrosted. The daily temperatures are monitored remotely, and it's same with the pharmacy. They will let us know if there's an issue. And of course, no specimens or medications can be in the nutrition fridge. That might sound like common sense, but in the day, that's exactly what we did. Safety and security. Okay, so staff, students, volunteers, anybody must wear an ID badge at eye level. Visitors must check in with security and display a visitor ID badge. Workplace violence is to be reported to security, and security's number is 856-111. Please make sure that we don't prop open any doors, and fire exit doors are closed. Oh, what's this? Our door is broken again? Okay, so anything that is broken is reported and a work order is submitted to get it fixed. Of course, we know that there should be no smoking on hospital premises, even outside. Can you imagine, back in the day, the patients actually smoked in their rooms, and we had special smoking areas for the staff and patients in all of the hospitals. Biohazardous waste and materials must all be labeled correctly. They have to have the original label or a typed label that identifies all of the contents. They need to be stored correctly, and of course, all biohazardous waste is disposed of in red bags. Okay, all employees have the right to know what chemicals and hazardous materials are in their workplace. So you need to know where the safety data sheets are, and that will be also Net Portal Content Directory. Okay, the SDS sheet will contain information about the product, safe handling, what PPE you need, and what to do if you were exposed, and as well how to clean up if there was a spill. Eye wash stations, we do not actually have eye wash station in SICU. We don't need one because we don't have anything corrosive that would damage your eye. So it's important that everybody's clear on that, because it's like a trick question, right? So we do not have eye wash stations in SICU, period. Next, some general life safety issues. So keep all storage 18 inches from the ceilings. Again, no door stops. We should not have holes in the walls or the ceilings, and Erwin keeps on top of that for us. No paper or tape on the walls. Fire extinguishers are current, and they are. All exit signs are lit, and the arrows go in the correct direction. That would be good. Do not block the exits. Do not store anything in the stairwells, and we're always on the lookout for that. No paper boxes are on the floor, and why is that? Fuel for fire. So not only do critters come in on the boxes, but as far as life safety goes, it's fuel for fire. Oxygen tank storage. So this should be pretty self-explanatory. Red is for empty containers, green is for full containers, and yellow is for anything in the middle. What is an empty container? It's under 500 psi, it's in the red zone. And of course, the spirit of this measure is that it's highly unfortunate to grab an empty tank when you're traveling with a patient or have an emergent situation. Fire safety, always a hot topic. Ha ha ha. So it would be mortifying if we didn't know what RACE stood for. And that might sound funny, but when somebody puts you on the spot, sometimes it's hard to articulate. So rescue, you would rescue anybody in immediate danger. Alert or alarm, telecommunications, pull the alarm. Confine the fire as much as you can, and extinguish the fire if that's reasonable. The safety inspector will want to see that the employees have awareness. So where is the nearest pull station? Where is the nearest fire extinguisher? Who decides when to evacuate? Where do we evacuate to? Horizontal versus vertical evacuation. Where is the medical gas shut off, and who can shut off the medical gases? So when you're in the unit next, make a point of, eyeballing where the pull stations are. Remember, on the A side, it's a bit of a trick because the pull station is located down by the call room at the end of the hall. Same for fire extinguishers. They're usually by the exit doors, but we've got some tucked behind some doors. And remember that you would always bring at least 2 fire extinguishers to a fire. If it were necessary to evacuate horizontally, we would know that we would take our patients beyond the fire doors to A side, B side, or PACU, many choices depending on really what the circumstance is. So we know these are fire doors because they have a metal label on the inside that lets us know what the burn time for these doors are. With any luck, they'll be fixed when the surveyors are here and not stuck in the open position. And the person who would let you know that it's time to evacuate horizontally would be the charge nurse or the AIC. Although very unlikely, if we did have to vertically evacuate, that would be the fire marshal that would give us that direction. So you would need to know where are the fire exits in your unit, and also be aware that at the end of the hallway in the DTC, the stairwell there is a fire exit. If there was a fire in the unit and we needed to shut down the medical gases, it's important to know that the person that decides to shut down the gases really needs to know who's on oxygen in the unit. So that would be nursing supervisor, charge nurse, or respiratory supervisor. Also, you want to know where the shutoff valves are for each unit and what beds they control. So again, you want to know where the fire extinguishers are in the unit, and that if there was a fire, you're going to bring at least 2. Obviously, you need to know the acronym PASS. So PASS, it would be pull the pin, aim at the fire, squeeze the handle, and sweep at the base of the fire. Next topic is electrical safety. Okay, so all biomedical electrical equipment is tagged and current. All other electrical equipment has been tagged before using it. No 2-pronged appliances are to be used within the facility. That's why we hide everything. No wire nests are to be found under the desks. Patients should not bring in electrical devices from home, only battery operated. Extension cords are illegal. We should not be using them unless they're hospital grade, and we should not be using daisy chains. So what is a daisy chain? So a daisy chain is when you hook multiple devices into each other. So we suspect that we've got a daisy chain here. Actually, we've got a couple things going on. There's too many pumps on this pole. From an infection control perspective, those pumps and the tubings are too close to the ground. So another question that surveyors ask are, how are you competent to work in this unit? So it sounds like a trick question, but it's really not. So you would say that you had an amazing orientation when you first started here with an amazing preceptor, that you have transplant education, LVAD education, trauma education, and about 1,000 We Learn modules. There is just-in-time and ongoing education throughout the year. You maintain your ACLS and BLS, and as well your RN license. And of course, that's when the surveyor will head down to the war room to make sure that all of that documentation is in your file. Okay, hang in there. We're almost done. I know that's an awful lot of information. Let's take a little break before we reconvene.